Let's put ourselves right in the resuscitation bay. You've got a patient who just rolled in, acute onset hemiparesis, gaze deviation. The whole presentation just screams large vessel occlusion.
Yep.
You rush them to the scanner, the CTA confirms it, proximal MCA occlusion. The clock is ticking, the team is mobilizing for the angio suite, and you have that split-second decision that defines the entire workflow.
Right. The question isn't whether we intervene. We know we need to get that vessel open. The question is the sequence. Do we stop to mix and hang intravenous thrombolysis as a bridge while the cath lab is prepping?
Or do we skip the lytic entirely and just go straight to mechanical thrombectomy?
Exactly.
It's the classic direct versus bridging debate. And honestly, for a long time, I feel like the default setting in most of our heads has been bridging.
Oh, absolutely. If they're eligible for the drug, you give the drug.
It feels like we're maximizing our firepower, We're throwing everything we have at the clot.
It's the belt and suspenders approach. The rationale has always been fairly intuitive. We think, okay, while we're waiting for the interventionalist to scrub in or while we are transporting the patient, the lytic is circulating.
Best case scenario.
Best case, you get early reperfusion before you even puncture the groin. Worst case, you've at least softened the thrombus, maybe made the mechanical extraction a little bit easier.
Right, that's the intuition. But we are here today because, well, intuition doesn't always match the data. We're looking at optimizing the sequence, specifically looking at timing and anatomy.
Because there is a very real counterargument. Is stopping to administer the lytic, even if it's just a 10 or 15-minute delay, actually burning precious neuron time?
Is that safety net actually just a procedural delay?
That is the crux of it. And when you look at the broad data, safety isn't actually the primary differentiator here. We know that, generally speaking, mortality rates and symptomatic intracranial hemorrhage rates are. They're statistically similar.
Which is interesting in itself, because I think a lot of us worry that adding the lytic significantly increases the bleed risk. That fear of going systemic with TPA and then poking around with wires.
It's a valid concern, and logically it makes sense to worry about that, but the data suggests it's comparable. The real battleground isn't about avoiding death or avoiding a bleed. It's about efficacy. We are fighting for functional outcome.
For that modified Rankin scale score of 0 to 1.
Exactly.
Okay.
And that is where the one-size-fits-all protocol fails us. We can't just say always bridge or never bridge. We have to look at the specific variables that drive efficacy.
And the loudest variable in this equation is time. We have a specific metric we need to drill into today. 2 hours and 20 minutes.
2 hours and 20 minutes. This is the timestamp that needs to be burned into the decision tree. It's the inflection point where the strategy needs to change.
Okay, so let's unpack that window. What happens if we are under that 2 hour and 20-minute mark?
If you are within that window, meaning you can actually get the bolus into the patient within 2 hours and 20 minutes of their last known well, the evidence strongly supports the bridging approach. Give the lytic.
And why is that specific window so potent? Is it just about the penumbra or is it the clot itself?
It's both. It really comes down to clot physiology and the penumbra. In that early phase, the thrombus is often more susceptible to chemical dissolution. It hasn't fully organized yet.
Right.
And the ratio of salvageable tissue to infarct core is usually more favorable. The data shows that when you administer IVT this early, the functional benefits just do. They outweigh the risks. You are statistically more likely to improve that patient's long-term independence.
So in that early window, the drug is doing enough heavy lifting to justify the time it takes to give it.
Precisely. It adds value to the procedure. You might get recanalization before the sheath is even in, or at least fragmentation of the clot that makes the thrombectomy faster and cleaner.
Okay, now let's cross that line. We're at 2 hours and 30 minutes. Or 3 hours. The patient is still technically eligible for TPA or TNK per the guidelines. We have that 4.5-hour window ingrained in us.
Right.
But we've passed this specific efficacy window of 2.20. What changes?
The curve shifts. Once you push past 2 hours and 20 minutes, the added benefit of the lytic begins to decay significantly. The chemical dissolution becomes less effective, maybe the clot is more organized, or maybe the metabolic crisis in the brain has just advanced.
So the time cost of administering the drug starts to outweigh the potential benefit.
It does. So the strategy flips. It flips completely.
Wow.
If you're looking at a time frame beyond that marker, the recommendation shifts toward direct thrombectomy. Your priority becomes purely mechanical.
Yeah.
Get the wire up there and physically remove the obstruction. Don't fiddle with the chemistry, focus on the physics.
That's a massive mindset shift. I think the tendency is often, well, we're still within 4.5 hours, so we give it. But you're saying that clinical eligibility isn't the same as clinical optimality?
That's it exactly. Eligibility gives you permission to treat, but it doesn't mandate the strategy. We have to ask, is this drug going to change the outcome for this patient at this specific time? And the data tells us that late window lytics in LVOs often just delay the definitive treatment.
It becomes a distraction from the cure.
A distraction and a delay. And in stroke, delay is disability.
Now, obviously, time isn't the only variable. We aren't treating a generic blockage. How does anatomy overlay with this time window?
This is critical. The bridging rule, that preference for IVT first, is really built on data from anterior circulation strokes. We're talking ICAs, M1s, proximal M2s. That's where the bulk of our randomized data lives.
And if we're dealing with a posterior circulation stroke, a basilar occlusion...
That's a different beast. There's a distinct lack of high-quality evidence supporting routine bridging in posterior circulation strokes. The pathophysiology can be different, often harder, calcified emboli, where dialytics might not be as effective.
Plus, the stakes with the basilar are so incredibly high.
Right. The volatility of the brainstem. So the default to bridge is much weaker there. Generally, if you have a confirmed basilar occlusion, the bias is to get to the lab immediately.
Let's zoom in on the anterior circulation, though. You mentioned M2 segments. I've always found these tricky because they are accessible, but it's technically more challenging than a nice big M1 occlusion. It's more torturous, it's smaller.
And that difficulty is exactly why anatomy matters here. Distal occlusions, like those in the M2 segment, actually tend to benefit more from the bridging strategy.
Because the mechanical option is less of a slam dunk.
Right. Navigating a catheter into a tortuous M2 branch carries higher risk of perforation or vasospasm, and sometimes you just can't get the clot out completely. In those cases, the hemolytic acts as a crucial adjunct. It can work on those smaller distal vessels that the catheter might struggle to clear. It kind of cleans up the mess.
So if I have an M2 occlusion, even if I'm pushing that time window a little bit, I might lean slightly more towards giving the drug because I know the procedure itself is going to be tougher.
That's a reasonable clinical synthesis. The penalty for skipping the lytic in a distal occlusion is potentially higher because you don't have the same guarantee of mechanical success. You want that chemical backup.
What about tandem occlusions? We see this a lot. A proximal ICA stenosis plus an intracranial embolus. There's always this fear in the room that if we give TPA and then we have to stent that carotid, we are asking for a bleed.
It's a pervasive fear, but the evidence doesn't back it up. Patients with tandem occlusions do not carry a higher bleeding risk with thrombolysis. Bridging therapy remains a completely valid and often favored approach.
So don't withhold the chelictic just because you see a tandem lesion.
Do not.
Yeah.
You treat the thrombus chemically while you manage the stenosis mechanically. Treat the stroke. The interventionalist can handle the hemostasis.
Okay, so we've got the timing, that critical 2-hour, 20-meter mark, and the anatomy. Now let's talk about the hard stops, the operational reality.
Well, you have your absolute clinical contraindications, obviously. High bleeding risk, recent major surgery, active hemorrhage. In those cases, the debate is over. You go direct thrombectomy. That's straightforward.
But what about the logistical contraindications? I feel like this is where the rubber meets the road.
This is the workflow factor.
Yeah.
And frankly, it's where systems often fail the patient.
Yeah.
If you are working in a facility where the door-to-needle time is consistently slow, maybe the pharmacy is far away, or the mixing protocol is cumbersome, and that delay is going to push administration past that effective window.
Yeah.
You have to skip it.
That requires a lot of self-awareness from the stroke team. To admit, we are too slow to make this drug work.
It's not about ego, it's about efficacy. If your logistics undermine the biological benefit, then the strategy has to change. If you know it takes 45 minutes to get the bolus ready, and the patient is already at 2 hours post-onset, you are actively harming the patient by waiting.
So the algorithm isn't just, what does the guideline say? It's, what does the guideline say, plus what does the clock say, plus can my hospital actually pull this off fast enough?
Exactly. You operationalize the decision based on reality, not just theory.
I want to pivot to some of the pitfalls we see. We've touched on the default instinct, but let's talk about that always give it trap.
This is the mindset that thrombolysis is always beneficial, regardless of the clock. It's a cognitive trap. We equate treatment with helping. But as we discussed, outcomes data shows diminishing returns. You'll inevitably overtreat patients in the late window who would have been better served going straight to the lab.
It's hard to break that habit, though. It feels like withholding care.
It does. But we have to reframe it. Withholding a low-yield drug to expedite a high-yield procedure isn't withholding care, it's optimizing care. It's actually the more aggressive move.
Another pitfall is observational bias. How does that skew things?
Well, observational data is messy. You look back at a registry and see that patients who got bridging did better. But you have to ask, why were they selected for bridging? Probably because they presented earlier, were more stable, had fewer comorbidities.
Selection bias. The bridging patients were healthier to begin with.
Huge selection bias.
Yeah.
That's why we need to rely on the specific frameworks of timing and anatomy that come from the randomized trials, not just what usually seems to work.
And sticking with that rigorous analysis prevents overgeneralization.
Right. Treating all LVOs the same is dangerous. An M1 occlusion is not an M2. An ICA terminus is not a basilar. If you try to apply the same protocol to every vessel, you will miss the nuance that drives recovery.
So let's synthesize this. A clinician is on their way to a shift. They get that page, stroke alert, LVO confirmed. How do they process this in real time?
You need a checklist in your head. First, look at the anatomy. Is it anterior circulation? If yes, proceed. If it's posterior, you are likely going direct MT.
Okay, anterior circulation confirmed. We see the cutoff on the MCA.
Next, look at the clock. Not just time last known well, but time to anticipated needle. Can I get this drug into the vein within roughly 2 hours and 20 minutes of symptom onset?
If the answer is yes.
If yes, and no medical contraindications, you bridge. You start the IVT immediately and move to the angio suite.
And if the answer is no, if we're at 2 hours, 45 minutes, or my ED is slammed and I know the drug won't be hung for another hour,
then you skip it. You proceed directly to mechanical thrombectomy. You prioritize the physical removal of the clot.
That's clean. And it gives permission to not do something if you have a good reason.
It clarifies the mission. The mission is reperfusion. The method depends on the constraints.
I think the nuances regarding the distal occlusions are worth reiterating one last time. If I see that M2,
You hold on to the bridging strategy a little tighter, yes. The mechanical risk profile makes the pharmaceutical help more valuable. Don't be too quick to abandon the lytic on a distal clot.
and regarding the tandem occlusions, don't be scared.
Don't be scared. Treat the stroke. Don't let the carotid pathology prevent you from saving the brain parenchyma.
So before we wrap up, let's crystallize that one-line rule. If our listeners take away nothing else, what is it?
Here it is. Administer intravenous thrombolysis before mechanical thrombectomy in eligible anterior circulation LVO patients. If it can be given within approximately 2 hours and 20 minutes of symptom onset and no contraindications exist. Otherwise, proceed directly to thrombectomy.
Clean, simple, evidence-based.
And it accounts for both the patient's physiology and the hospital's logistics.
Which brings me to a final thought. We've spent this time talking about how to make decisions within the current system, but this 2 hour and 20-minute window, it puts a massive spotlight on our systems of care.
It does. It raises an uncomfortable question. Are our hospital workflows actually fast enough to keep that window open? Or does the inefficiency of our own systems force us toward direct thrombectomy?
And if we're defaulting to direct MT just because we're too slow to mix a drug?
That's not a clinical victory, that's an operational failure.
Something to think about the next time you are looking at those door-to-needle metrics.
Absolutely, the clock is always running.